Well, we've all heard a lot about opioids recently, and most of it has not been very good, regardless of whether you're in the more pro-opioid camp or the anti-opioid camp. There's certainly a lot more scrutiny around prescribing, a lot more warnings, such as the recent black box warning on combining opioids and benzodiazepines, and at many different levels of law enforcement, people are getting involved in scrutinizing really what we're prescribing and how that affects the current opioid epidemic. So I want to talk today about some adjuvant therapies for pain management. First, I'm going to review the evidence for perioperative pain management guidelines. Then I'm going to talk a little bit about how acute pain can develop into chronic pain, and this will tie in nicely with the acupuncture talk that we just heard. And finally, I'm going to review some non-opioid medications for chronic pain management. Before I talk about perioperative pain adjuvant therapies, I just want to remind everybody that opioids do remain the mainstay of perioperative pain management. So right now, we're not doing a very good job with perioperative pain. More than 80% of patients who undergo surgical procedures experience acute postoperative pain, and 3/4 of those say the pain is from moderate to extreme in severity. And fewer than half of patients who undergo surgery report adequate postoperative pain relief. So why is this so important? Why is it important to manage a patient's pain perioperatively? Postoperative pain can contribute to significant morbidity and mortality. It can impact recovery and delay return to daily activities. It certainly decreases the patient's quality of life. It can increase post-surgical complications, and it may precipitate persistent post-surgical pain. Typically, acute pain resolves within a month. That varies significantly depending on the type of the surgery. But if acute pain is poorly managed, it can become chronic. So I'm going to review some of the guidelines on the management of perioperative pain, which were put out by the American Pain Society, American Society of Regional Anesthesia and Pain Medicine, and American Society of Anesthesiologists. First of all, they recommend an individually tailored plan and goals for postoperative pain management. This can be something as simple as talking to your patient about what has worked for them in the past, explaining what's going to happen while they're in the hospital, and what you're going to do for them for pain management when they go home. This has been shown to reduce postoperative opioid consumption, decrease preoperative anxiety, decrease requests for sedative medications, and decrease the length of stay after surgery. So it sounds like one of those things that we all sort of run away from because we don't want to put the time into making an individually tailored plan, but it really does save us time in the long run. First of all, this task force recommends multimodal analgesia, and that means a variety of analgesic medications, a variety of analgesic techniques, and also non-pharmacological interventions. They recommend acetaminophen or NSAIDs when they're not contraindicated. For example, celecoxib, 200 to 400 milligrams, or about 30 to 60 minutes pre-op. Gabapentin and Pregabalin are also potentially very helpful. 600 to 1,200 milligrams of gabapentin or 150 to 300 milligrams of pregabalin given 1 to 2 hours preoperatively. In one study of arthroscopic ACL repair patients, 1,200 milligrams of gabapentin given 1 to 2 hours before the surgery decreased their post-op morphine requirement by 50% and improved early post-op knee flexion. So that's a significant impact. Gabapentin and pregabalin will improve epidural analgesia. They decrease delirium and anxiety, and they are synergistic when combined with a COX-2 inhibitor. And so all of these are strong recommendations with either moderate or high quality evidence. You might also want to consider a ketamine bolus followed by an infusion. Hopefully everybody who does surgery is infiltrating with local anesthetic whenever possible. That's a very easy way to attenuate the pain response at the local tissue level and provide some good pain relief in the immediate postoperative period. The task force also recommends regional anesthetic techniques, and I really want to emphasize this because I hear all the time that surgeons feel regional anesthesia takes too much time, they don't want to wait around for it, they don't like the extra attention it requires while the patient is recovering in the hospital, and they perceive it as prolonging the hospital stay. In fact, regional anesthesia, which for example would be a continuous peripheral nerve block, like a FEMPOP catheter or an epidural, is superior for analgesia when compared to opioids, has fewer side effects, it facilitates hospital discharge, and it has greater patient satisfaction. There can be neurologic and infectious complications, but those are rare. And that is a strong recommendation with high quality evidence. Neuraxial analgesia is a good option to consider for major thoracic and abdominal procedures, especially in patients who are at risk for cardiac complications, pulmonary complications, or prolonged ileus. Epidural analgesia is superior to systemically administered opioids. A thoracic epidural improves coronary blood flow. It can attenuate pulmonary complications, for example, in a patient with rib fractures. If they have so much pain that they don't breathe deeply, they can get hospital-acquired pneumonia. And it reduces the duration of post-op ileus. That's also a strong recommendation with high-quality evidence. The task force also recommends that you consider cognitive behavioral modalities and Dent. And at the time when they wrote this, which was in February of this year, there were not enough large-scale randomized controlled trials for them to recommend or discourage acupuncture, massage, or cold therapy. So in chronic pain patients, it's especially important to have good perioperative pain management. You want to use regional analgesia when possible. It sounds silly to say it, don't start a wean of their baseline opioid doses post-operatively, but I've seen patients come out after surgery. I had a patient who had a heart valve replacement, and he went home with the same exact dose of medication that he was on before the surgery. This is not the right time to worry about the long-term picture of what your patient is on. You do want to give the daily maintenance or baseline opioid dose. A good way to do that is a PCA with a basal rate, or a long-acting oral opioid. And on top of that, patients typically need 30 to 100% more opioid than their preoperative dose, depending on the type of the surgery. So why is this so important? Of course, it's important for things like patient satisfaction, pain relief, length of hospital stay, but it's also important because poorly managed acute pain can develop into chronic pain. This is a fascinating process that involves tissue damage, peripheral and central sensitization, allodynia and hyperalgesia, which we heard about from Erin, NMDA receptor activation in the dorsal horn, and a number of other pathologic things that occur in the nervous system. And I'm going to elaborate on all of these, don't worry. Neuropathic pain is more likely to progress to a chronic pain state, and neuropathic pain would be pain that's caused by a nerve injury, such as an entrapment, cutting with a scalpel, traction with a retractor, compression by poor patient positioning. And it's typically burning, paroxysmal shooting pain, electrical sensations, and it involves allodynia, hyperalgesia, and dysesthesias. And like I said, I'm going to elaborate on many of these terms. So, peripheral sensitization occurs by modulation of pain signals at the local tissue level. First, the tissue damage, whether that be a trauma or a surgery, activates nociceptors, which are the free nerve endings that sense noxious input. It releases inflammatory mediators like macrophages and mast cells, and releases substance P and glutamate, which are pro-pain neurotransmitters. Those cause vasodilation, extravasation of plasma proteins, and release of algogenic or pain-amplifying substances. There's increased nociceptor excitability at the C fibers and the high threshold mechanoreceptors. And all this results in primary hyperalgesia, which is an exaggerated response to pain at the site of the injury. So hyperalgesia is like if you were to dig your fingernail into your forearm. It hurts a little bit, but not much. If you were to dig your fingernail into your surgical scar on post-op day 1, that would hurt a lot. That is hyperalgesia. With central sensitization occurs when substance P and glutamate activate the NMDA receptor at the dorsal horn. that can result in persistent C fiber activation, which increases the response to stimulation at the dorsal horn and enlarges the receptive field at the dorsal horn. So the dorsal horn has wide dynamic range neurons, which receive input from both noxious and non-noxious stimuli. And with this persistent activation, the dorsal, it can actually respond to the non-noxious stimulus in the same way that it responds to a noxious stimulus, meaning that a non-painful stimulus can actually precipitate pain signals. And this is called central sensitization, or wind-up is the old term for that. That causes hyperalgesia and also allodynia, which is when a non-painful stimulus is painful. So for example, if you just drag your fingernail along your forearm, that's not painful. But again, if you're going to do that along your surgical scar, it would be. Central sensitization has implications beyond just pain. Vagal dysregulation decreases endorphin release, changes serotonin and norepinephrine production and utilization, changes perception of mild pain, and increases depression. Sympathoafferent coupling decreases parasympathetic drive and increases sympathetic drive, leading to increased norepinephrine release, which causes dysfunctional sleep and anxiety. Decreased medullary descending inhibition of nociception. So decreasing inhibition means the outcome is increased signaling. Increases the peripheral nociceptive input and causes hyperalgesia and allodynia. And hypothalamic pituitary adrenal hypoactivity and changes in the autonomic nervous system cause increased sympathetic tone, decreased vagal tone, fatigue, and malaise. So you're starting to see how chronic pain patients are different from acute pain patients, and probably a lot of this is sounding familiar. The altered perception of mild pain, the increased depression, the dysfunctional sleep, the anxiety, hyperalgesia, allodynia, fatigue, malaise, it's starting to sound like the chronic pain patient. And what's fascinating to me about this is once central sensitization is well established, even removing the noxious stimulus may not remove the perception of pain. Interestingly enough, we can actually predict with very high accuracy which acute pain patients will will progress to have chronic pain. This was a study of, it was actually a series of studies of acute low back pain patients referred to an occupational medicine clinic who underwent a biopsychosocial evaluation within 6 weeks of their injury. And 3 factors were found to be predictive with 90.7% accuracy of which cases would progress to chronic pain. Those were self-reported pain and disability, scores on scale 3 of the MMPI, which is a 600 question battery, and that scale 3 measures hysteria, and workers' compensation and personal injury insurance status. The presence of a personality disorder was also found to be somewhat predictive. Interestingly, and I want to emphasize this last one, depression and substance abuse are not predictive of chronic pain. Now, there are some other studies that have shown a link between depression and the development of chronic pain. But more typically, studies reinforce the fact that chronic pain itself predisposes to depression. So it actually happens the other way around. And these are some surgeries that have a high risk of triggering chronic pain. Amputation is sort of the case in point, the classic one. I have some post-mastectomy syndrome patients, and then here are some others. So our goal in the perioperative period should be successful preemptive analgesia, which means blocking all nociceptive input during surgery and in the postoperative period, so some of this peripheral and central sensitization doesn't even begin to occur. And it's a challenge in chronic pain patients because they're already sensitized, and it is probably going to be more difficult to achieve successful preemptive analgesia, which is why marshaling all these alternative resources is so important. So when you are picking medications for chronic pain, the first thing to do is think about what you're treating. Is it nociceptive pain, which typically occurs in response to tissue damage? It may be somatic, which is discrete and intense. Patients can typically put one finger on the location of the pain. It may be visceral, which is diffuse and poorly localized. And it may be inflammatory, which is more associated with post-operative pain or arthritis. We talked a little bit about neuropathic pain earlier. That occurs when you have a peripheral or central nervous system lesion. And some examples of neuropathic pain are diabetic peripheral neuropathy, complex regional pain syndrome, trigeminal neuralgia, post-herpetic neuralgia, and central post-stroke pain. And when we have no idea what's going on, we call it dysfunctional pain. So if you're treating nociceptive pain, think reduce inflammation with NSAIDs, block nerve fiber activity, maybe with ion channel blockers, act on C fibers, for example with capsaicin. If you're looking at neuropathic pain, anticonvulsants, antidepressants, local anesthetics, and NMDA antagonists, for example ketamine, are going to be your primary tools. And for dysfunctional pain, the best way to start is to treat it like neuropathic pain, but really whatever works is okay. It's typically advisable to stay away from opioids when you can't document a source of the pain. So traditional medical treatments have really aimed at just one aspect of this pain transmission pathway, which is perception. But there are options for all levels. We can act at transduction, which is when a peripheral nerve fiber senses a noxious stimulus and converts it into the action potential that will be carried through the nerve. We can act on transmission, which is what happens as the first and second and third order neurons carry that signal. Fourth, we can act at the brain, where perception occurs. But to me, what's most fascinating about chronic pain is the third part, which is modulation. There are ascending and descending pathways, primarily in the dorsal horn of the spinal cord, that influence the pain signal transmission. They can amplify or mute that transmission. So specifically, with the antidepressants and antiepileptics, you can have a significant impact on neuropathic pain, fibromyalgia, musculoskeletal pain, visceral pain, headache, and also on sleep, depression, and anxiety. And while I don't personally prescribe them as primary treatments for sleep, depression, and anxiety, most of my patients have problems with all three, and so I certainly see the benefits as sort of a beneficial side effect of these medications. The best evidence is for the antidepressants, antiepileptics, and lidocaine patch, specifically among the TCAs, amitriptyline, nortriptyline, and desipramine, and among the SNRIs, duloxetine. For the antiepileptics, there's very good evidence for gabapentin and pregabalin, and there's very good evidence for the lidocaine patch as well. There's second-line evidence for opioids and tramadol, and less evidence for other treatments. So duloxetine is FDA approved for diabetic peripheral neuropathy, fibromyalgia, and chronic musculoskeletal pain. And there is some evidence for high-dose venlafaxine, although I have to say the only time I've ever used it is when I was at the VA and we weren't allowed to use duloxetine. There's really not, unless you have a specific reason not to use duloxetine, I wouldn't recommend venlafaxine. Tricyclic antidepressants are first line for neuropathic pain and headache. They're preventative of migraine. The data tends to be older and less robust, but there is a long history of experience with these medications. Keep in mind that many of the tricyclics have significant side effects, so don't just click OK when the little warning box comes up. You want to think about these medications in the context of whom you're prescribing them for and what other medications the patient is taking and what other chronic health conditions your patient has. It's really hard for patients to understand why you're giving them these medications. They'll read the prescribing information and say, I don't have seizures, I don't want to take gabapentin. Or they'll tell you how their pain occurred, how bad the injury was, how severe the trauma was, how much they suffered for the last 20 years, everything they've tried. And you'll think, why are we hearing this again? And it'll be because they're trying to convince you that their pain is real because you're prescribing something that suggests that it's just in their head. So I tend to explain to patients that we've discovered that many of the chemicals that do pain also do mood, and therefore many of the drugs that do mood also do pain. Keep in mind with these medications that analgesia can take time. And I just want to remind everybody that SSRIs are not pain medications. So with the antidepressants, with the tricyclics, you want to start low and go slow, and again, anticipate side effects. They tend to be underdosed for chronic pain. The target dose is usually 50 to 150 milligrams a day. Don't forget to check an ECG, as many of them can prolong the QT interval. And again, keep in mind that there's several interactions with other medications. Nortriptyline and desipramine are often better tolerated, especially in the elderly, as they tend to have fewer side effects compared with amitriptyline. But amitriptyline causes significant sedation, and it does help people sleep. For duloxetine, you want to start at 20 to 30 milligrams a day with food. Nausea is pretty typical, but it does usually subside after the first week. And the target dose is from 60 to the maximum of 120 milligrams a day. Gabapentin is FDA approved for post-traumatic neuralgia. Pregabalin is approved for diabetic peripheral neuropathy, post-traumatic neuralgia, fibromyalgia, and spinal cord injury pain. It's also used as an anxiolytic, and I think gabapentin now is being used more as an anxiolytic as well. Topiramate and valproate are mainly helpful in chronic pain for migraine prophylaxis. And carbamazepine has a record in the treatment of trigeminal neuralgia. Beyond that, there isn't much evidence for other anti-epileptics in chronic pain. So gabapentin works by binding the alpha-2 subunit of the voltage-dependent calcium channels. It's not actually GABAergic. And it prevents the development of central excitability by stabilizing the neuronal membrane and decreasing the spinal cord response to pain fiber signals. So here's that modulation that we're talking about. It's anti-hyperalgesic. It prevents the development of severe pain in response to a mildly painful stimulus. And when combined with NSAIDs, there's a synergistic decrease in the hyperalgesia associated with inflammation. The main side effects are somnolence, dizziness, confusion, and ataxia. They can be real. You want to be sure that your patients understand how to take this medication. Despite writing out an up-titration plan for a patient, maybe a month or two ago, I had somebody who was supposed to be up-titrating to 300 TID. She went straight to 300 TID, got up in the middle of the night, had pain, took another one, and fell and fractured her C2 lateral mass. One positive side effect of gabapentin is that it improves restorative sleep. And by the way, patients who can't tolerate it during the day often say that they have sedation or they feel like they can't think clearly. It's possible to just move the entire dose to bedtime in those patients, and there are 2 long-acting preparations as well. Pregabalin works similarly to gabapentin. Topiramate works by blocking sodium channels. It enhances GABA at the GABA-A receptor, which means that it increases inhibition, and it antagonizes the AMPA kinase subtype of the glutamate receptor, which means that it decreases excitation. So that this medication also takes away from the central sensitization that occurs in chronic pain. And valproate likely has many mechanisms. Gabapentin is not metabolized and has no significant toxicity. Typically, you would start at 300 milligrams at bedtime. It says that the recommendations are to up-titrate quickly on a TID schedule, but like I said, patients have a hard time understanding this. I always write out an up-titration schedule every time I'm asking patients to do this. Once you get to 1,800 milligrams a day, you've had about 80% of the potential benefit from gabapentin for chronic pain. You can go up to 3,600 milligrams a day, which is the maximum. And I have many patients who are on that much, but keep in mind that milligram per milligram, as you go from 1,800 to 3,600, you're going to get more side effects than benefit comparatively. And renally dose it for patients with creatinine clearance less than 60, 600 milligrams BID. Compared to gabapentin, pregabalin is more potent. It's faster onset. It can begin working within 1 day, whereas gabapentin can take weeks or even months, especially as it takes time to up-titrate. It's more bioavailable, and it's potentially effective in treatment-resistant patients. And one study of post-operative neuralgia patients compared pregabalin with gabapentin and showed that those on pregabalin had lower opioid requirements than those on gabapentin. And by the way, some of my references did not make it into my slides. I apologize for that. I have full copies of most of these articles, so just get in touch with me afterward if you're interested. For some reason, BID dosing is more cost efficient than TID for pregabalin. I guess the little plastic capsules are incredibly expensive. But the effective dose range is 150 to 600 milligrams a day total. It was originally FDA approved for up to 450 milligrams a day, but there's good evidence for using it up to 600. It is a scheduled medication. It's Schedule 5. Side effects are nausea, dizziness, somnolence, edema, dry mouth, and weight gain. The edema can be significant, so you want to avoid it in patients in whom that would be a real concern. Patients always talk about the weight gain. They read the prescribing information and they come to me and say, I can't take this medication because I can't gain any more weight. It's rare for patients to gain weight, but when it happens, it can be up to 40 pounds. So I tell patients it's very, I don't tell patients that second half, I say it's very unlikely to happen, and if it starts happening, I take it seriously and change their medication. You also want to reduce the dosing in renal failure. And when converting from gabapentin, it's recommended to taper off gabapentin before starting pregabalin. But I had a patient just recently in whom I was doing this, and she really didn't tolerate tapering off the gabapentin. Then you want to do a cross taper, where you're coming down on one and up on the other at the same time. And again, that's very hard to explain to patients, so please write out the instructions, tell them to call you if they have any questions. Topiramate dosing starts at 15 to 25 milligrams a day, and for chronic pain, the target is 25 to 50 milligrams BID with a maximum of 200 milligrams a day, and you also want to renally dose it. Topiramate can cause anorexia and weight loss, and it increases the risk of kidney stones. Valproate starting dose is at 250 milligrams BID, thereafter up to 1,000 milligrams a day as needed. And it's complex metabolism and drug interactions can be real, so pay attention to other things that the patient is on. And like many of these medications, you want to avoid it in patients who are considering pregnancy. So let's talk about inflammatory pain treatments. Inflammatory pain is pain associated with ongoing tissue damage and inflammation. The pathophysiology is peripheral sensitization. I'm not going to go through all this because I see that I'm running out of time, but peripheral sensitization leads to hyperalgesia and allodynia. So NSAIDs work by blocking prostaglandin synthesis and inhibiting cyclooxygenase. Prostaglandin 2 is a key mediator of both peripheral and central sensitization. Peripherally, it causes sensitization by sensitizing nociceptors to other pain mediators like bradykinin and histamine, and centrally, prostaglandin enhances pain transmission by increasing the release of substance P and glutamate, increasing the sensitivity of second-order neurons, and inhibiting the release of inhibitory neurotransmitters. COX-1 is active at all times. It maintains platelet function, GI mucosal integrity, and renal function. And COX-2 is constitutive, meaning that it's not typically active in a healthy patient, but when activated, it causes inflammation, pain, hyperalgesia, and allodynia. At the GI tract, COX-1 inhibitors decrease mucus production, pH, and mucosal perfusion, and COX-2 inhibitors impair mucosal cell repair. Prostaglandins work to dilate renal blood vessels. They're not typically active in healthy patients, but in patients who have chronic illnesses like heart failure, volume depletion, etc., they can be crucial in maintaining that renal blood flow. So when NSAIDs decrease prostaglandin formation, patients with these chronic health issues are at risk for renal ischemia. And NSAIDs can also counteract the activity of blood pressure medications because when the GFR is decreased, the kidneys respond to increased water and electrolyte reabsorption. Unfortunately, selecting a COX-2 is not going to get you any benefit for the kidneys because COX-1 and COX-2 inhibitors have the same renal effects. There's also potential for toxicity, nephritis, and nephrotic syndrome. Ketamine is an NMDA receptor antagonist. It works by stimulating the NMDA receptor, which is involved in development and maintenance of persistent post-op pain, hypersensitivity, wind-up, allodynia, opioid-induced tolerance, and opioid-induced hyperalgesia. Clonidine is the main alpha-adrenergic agonist for use in chronic pain. I have several patients who are on 0.1 BID or 0.1 TID for hard-to-manage neuropathic pain. The benefits are analgesia, sedation, and anxiolysis. And side effects are sedation, hypotension, and bradycardia. So you do want to pay attention to the patient's vital signs chart over the last few weeks or months, and any other medications they're on that might affect the cardiovascular system. The mechanism is thought to be decreased release of norepinephrine. These medications are active in the brain, spinal cord, and periphery. And clonidine has a lot of good evidence as a pre-medication or an adjunct during and after surgery for perioperative pain. In one study, pre-medication before prostatectomy with what's really pretty easy to give, 3.5 micrograms per kilo PO followed by a clonidine patch, decreased post-op PCA and morphine requirements by 50%. Let's not forget the muscle relaxants. What I mainly want to say about these is baclofen should be scheduled. It's really not effective as a PRN medication. And let's also not forget the topicals. These can be very helpful. Lidoderm patches or jellies or creams, Flector patches, Voltaren gel, and I've heard some feedback from my patients about CBD creams and patches, especially for inflammatory pain.